Okay. Hi, my name is Ken Reinke. I'm a mental health counselor here on 5 South at Advocate Christ Medical Center in Oak Lawn. And we're going to talk today about how to de-escalate a patient that you might encounter during your day and what to do and what to see and how to approach it. So we're going to have some questions being asked, and we're going to have a lot of good material for you today. And if you have any questions, don't hesitate to go to your manager, and I'm hoping that this will be very informative for you. So we'll get the ball rolling right here. And basically what we can, the way we can start this off is to understand that you're going to be dealing with psychiatric patients whether they're diagnosed with a mental illness or not. A lot of folks have psychiatric problems and illnesses. Some are diagnosed, some you will see, some may just come up during their stay here at the hospital. And it's very important that you know how to deal with it if they start to escalate or even get out of control. So we've got a lot of good techniques, or at least some information here to get you off to a good start and to help you maintain the control and to deal with the situation in a healthy way. So we've got that. And basically I was asking earlier how this will all start, and it'll basically start off when you folks have report in the morning and when you're getting your shift-to-shift change report and to know what your patients are going through. And this will be your first indication if a patient is having issues or troubles or problems. You'll know if they're having psychiatric issues that you need to deal with, and then what they were going through from the day before or the shift before too. This way you can act accordingly, prepare yourself for the day, and then go on from there. So, you want to start off with a question?
I do. So, tell me, when you walk into your unit or you meet your patient or you're greeting your patient and you find that your patient is angry, he's in some sort of distress where all of a sudden he's going off on you for whatever reason. A lot of the nurses sometimes will think, their first thought is like, oh my God, this is going to be a horrible day. I should have just stayed home. Maybe if I, leave this patient alone, maybe he'll just calm down. Why is he so upset? What's happening? Maybe if you try something, or if he tries something, maybe you're thinking in your head, oh, he doesn't know who he's dealing with. So what can we do to help these patients either bring down their anger or their de-escalation, or actually prevent them from getting to that point where they've hit their wall?
Mm-hmm. Well, it begins with us. We basically can be an anchor for them. We can help them deal with this, again, in a healthy way. That's where the information comes in from the shift before, and to basically be that calmness that they need. Yes, everyone gets angry. Everyone gets angry. It's how that you deal with it. When you combine it with mental illness, it can be very scary. It can be very overwhelming. So basically, I've got some information that can help everybody in terms of dealing with this. You want to speak at the same level. So if the patient is starting to escalate with their voice, keep your voice nice and calm. Keep it kind of level with that. Don't raise your voice with theirs. It doesn't accomplish anything, and it might even make the situation worse. Give the person a chance to vent. It's okay for them to get these feelings out. As a matter of fact, venting is a healthy way of getting these feelings out. Once they expend this energy, once they get their emotions out, it might give us some information as staff in terms of how to deal with it further, and it's just a good way to get it out. It's a healthy way to get it out, all right? Listening to them. This is very, very important. We have had studies in the past where if staff members give patients 5 or 10 minutes of their time at one time, it's better to do that than sporadic periods of time throughout the rest of the shift. And we've had patients tell us that they had more quality care, or they believed and they saw that we were giving them more quality care just with that period of time that we gave them as a whole. So 5 or 10 minutes of time at one time is better than sporadic periods of time throughout the rest of the shift. That might be very, very beneficial. So you can see if that can help too. And also too, how can we help you? What can we do to help you with this issue? And a lot of times too, you may not have the answers, and you can tell them, you know what, I may not be able to have an answer for you, but I can sit and I can listen to you. What's wrong? What's bothering you? Now, if you're dealing with a person who's bipolar or very, very depressed, you're going to see a lot of emotions. You're going to see emotions that might go from one end of the spectrum to the other. So this will help you determine what you have to do to help them. If they're rambling and they're just going on and on and on and on and nothing's making sense, yes, continue to give support. Continue to say, you know what, we're here for you. But then maybe see if there's some medications that can help them with that. Because we tell folks all the time, you know, when this breaks, you may not understand what you're going through. You may not understand what you're experiencing now. And we have some medication to help that. You can go realistic and you can be simple with it. And you don't have to give a big dissertation about mental illness. You can just simply state, this isn't working right. Something broke. When my hand is broken, it's mechanical. When this breaks, it's chemical. And when that happens, your behavior changes. So that's why, Mr. Jones, your speech is rapid. That's why, Mary, you're not eating well and you're depressed. You're isolating yourself. These are the classic signs and symptoms of many of the illnesses that we deal with here. And it's not that they've chosen to do this, it's a sign and a symptom. And by this, then this way you can understand what they're going through, get the medication started, and also combine that with just being there for them, allowing them to vent, keeping your voice steady. That can help tremendously in terms of de-escalating.
Very good. Now, what if, in a situation, if you were to, you know, you're asking your patient, how can I help you? I see what you mean. Tell me more. You're conveying that sympathy. Sometimes, you know, even the nurses can hit a wall and internally escalate themselves to the point where they're saying, you know what's your problem? You know, don't talk to me that way. In what way can we not only help ourselves but help the patient? Is there any alternatives that we can, you know, is it okay to say to them, you know what, let me offer you some alternatives. You know, you don't need to speak to me that way. You know, I'm here to help you. Sometimes that message doesn't come along to them and may escalate the situation. What can we do in that situation?
Well, just with what you said there, staying positive is key. Because a lot of times what you do is you start this emotional tug of war. The person pushed you emotionally. They may interpret what you said as you pushing back. And that can just start that escalation even more. And that's what you don't want. And a lot of times what staff has to do is they have to develop this, in a sense, this thick skin, for lack of a better way of saying it, to where no matter what they say, we're still going to stay professional, but we can still be professional in terms of how we address or readdress what their concerns are. So just with what you said, you can respond to say, wow, it looks like you're really hurting today. You know, you seem so upset, so angry. What's hurting so bad? What's causing you to feel this way? Give alternatives. All right, yes, do you need someone to talk to? Is there chaplain services that we can recommend to you? Have you talked to any of your family members recently? Can I help you make a phone call? You want to give positive alternatives. You want to, in a sense, empower them to let them know that, you know what, you still have a say with this. And even though you're upset, let's deal with this in a healthy way. Again, it's okay to be upset. Acknowledge those feelings. I hear what you're saying. I know that you sound, or I see that you're very, very upset with this. That's okay. But then what do you do with it? Okay? To leave them alone for the rest of the shift, or to just, you know, okay, thank you, I appreciate it, and then walk away, there's no resolution, because then that anger and those emotions are just stirring. But to empower them and give them, if possible, that's the thing, if possible, give them a chance to do something about it. Well, you haven't seen your son, he didn't come last night, why don't we call him? Here, I'll make the phone call for you. To stay on a positive note, to do something in a positive way, in some way, shape, or form. And this is, again, where the report comes in. Talking with them for 5 or 10 minutes, like we talked about earlier, can make a difference towards the end of the shift. And then if they start getting upset again, hey, remember what we talked about earlier? Let's see what we can do. All right, and then resolve it that way. The support and reassurance here. Also to avoid that power struggle. We touched on that a little bit earlier. That's where that process comes into, where no matter what they say to you, we still have to be professional. We still have to do our jobs in a professional manner. And even if they call you the worst names on the face of the planet, we still have to have that professionalism. Yeah, you know, I'm sorry that you feel that way. I'm sorry that things are going so poorly for you. If it's going bad with a patient, maybe to acknowledge the fact that, well, maybe we need to switch and maybe another staff member can come in and fill in for me, and it might make a better situation. In some instances, female patients may be more comfortable talking with female staff members. It could be in reverse. Maybe a male patient needs to talk to a male staff member for some reason or whatever. It might be something as simple as that. So this is where you have to gauge what the situation is, what they're going through, and then what you can do. But there are specific rules that we must follow as staff to, like I said, to stay professional and to get the patient through this difficult period of time. What it comes down to is their benefit, their well-being, how we can help them as staff members, and how to get through a difficult situation that they might be in.
Okay. Now, with everything that you're saying, it seems to me that anger is something that often builds up.
Mm-hmm.
And, it goes from 0 to 60. It doesn't just go from one point to another. There's the in-between that typically usually builds up to an escalated situation.
Mm-hmm.
So I know that anger is an emotional response to feeling frustrated or hurt. And people tend to react because they want to stand up for themselves.
Right.
Can you explain to me some of the in-between that goes over what could anticipate or what could cause this patient to escalate to a point where, they're at that, where they've hit their wall?
You want to take the fuse out before the bomb blows up.
Basically, yes.
A lot of times, and this could be when a person is being admitted, it could be before a procedure, it could be before a blood draw. It starts with anxiety. It starts with irritability. It could be fear. And what we ask patients is, what's your definition of anxiety? And in many instances, a commonality of all of this is not being in control. And think about it. When you come into the hospital, you're being told what to do. You're being told where to go. A lot of that causes anxiety. A lot of that will turn that anxiety into anger. So if you can anticipate that, nip it in the bud beforehand, that will basically prevent a lot of the anger that might come along down the road. And especially if you have a person who's never been ill before, who's never been in the hospital many years and so forth. Or you might have a person who's taking care of their loved one who's been in the hospital time after time after time again, and you have the other end of the spectrum here. So it really will depend, but it also will be what we can do to identify that and deal with it instead of letting it go and then coming back later. And I know we have our busy times, I know we have our paperwork we have to do, our computer work that we have to do, let alone all the machines that we have to deal with. But in many instances, if you can recognize that, say, Mr. Jones is going to have his MRI in a couple hours and he's really claustrophobic, what can we do to address it now so that before he goes down for the exam, he's not literally shaking out of his boots or becoming very paranoid or angry to the point of paranoia. So a lot of that is identifying it and getting it at the beginning. In many instances, what we've learned and what we've seen, much of what a patient goes through starts at that low anxiety level, and it builds up into that anger and that even violent part of it, and that's what you don't want.
And those are some of the consequences that can
escalate
afterwards.
And think about it too. Will the test get done? Mr. How long is an MRI? 45 minutes to an hour? If he's shaking and getting angry and nervous beforehand, how can we ask this person to literally be still for 45 minutes to an hour?
Right.
So there's your consequences like there. The behavior might escalate to abuse. It might escalate to verbal threats, to physical threats. And that's what you don't want. And then by then, the patient's well-being definitely is not being taken care of. All right?
So before becoming familiar
Can you pause it for a second? In the hospital many years and so forth. Or you might have a person who's taking care of their loved one who's been in the hospital time after time after time again, and you have the other end of the spectrum here. So it really will depend, but it also will be what we can do to identify that and deal with it instead of letting it go and then coming back later. And I know we have our busy times, I know we have our paperwork we have to do, our computer work that we have to do, let alone all the machines that we have to deal with. But in many instances, if you can recognize that, say, Mr. Jones is going to have his MRI in a couple hours and he's really claustrophobic, what can we do to address it now so that before he goes down for the exam, he's not literally shaking out of his boots or becoming very paranoid or angry to the point of paranoia. So a lot of that is identifying it and getting it at the beginning. In many instances, what we've learned and what we've seen, much of what a patient goes through starts at that low anxiety level, and it builds up into that anger and that even violent part of it, and that's what you don't want.
And those are some of the consequences that can
escalate
afterwards.
And think about it too. Will the test get done? How long is an MRI? 45 minutes to an hour? If he's shaking and getting angry and nervous beforehand, how can we ask this person to literally be still for 45 minutes to an hour?
Right.
So there's your consequences like there. The behavior might escalate to abuse. It might escalate to verbal threats, to physical threats, and that's what you don't want. And then by then, the patient's well-being definitely is not being taken care of. All right.
So before becoming familiar.
Can you pause it for a second? Hello, America.
So you're telling me, just to sum things up, and let me know if I'm wrong, the biggest thing with becoming familiar with de-escalating techniques and, an angry patient, whatever situation you may encounter, the first step is to staying calm and being in tune with the patient and being mindful not to take things personal.
Correct.
Is that right?
Correct.
Okay.
And it's even more difficult if you're having a challenging day. Say it takes a while to get to work, traffic jams, a bus or a train is longer than expected, and you walk through the door and you're in a bad mood to begin with. We've got to be professional enough to put that aside. And then when you're dealing with patients who are having bad days themselves, it's challenging for us to be empathetic and be caring and so forth, but we still have to do it because that's what we do. I've got a definition here. It's called rational detachment. And basically it's the ability to remain in control of our own behavior and not take the client's behavior personally. If it's a day-long thing, if it's 12-hour shifts, and you're dealing with a difficult patient and you're having a tough time, talk with your supervisor, talk with your shift manager, and see if you can trade off or if someone else can help in some way, shape, or form to help relieve some of that stress and tension that you might be going through. Because it will build up, and that's what we don't want. And then this way you can deal with it, you can get through the day, but most importantly, the patient can still get the care that they deserve. All right. So what do you need to do to take care of yourself, and then what do we need to do to take care of the patient? Because both of those, they do go hand in hand, and one does affect the other. Okay.
Thank you for that. That was actually I really enjoyed that that definition. I just want to go over a couple of scenarios just to kind of tie everything that we've talked about and just put everything together. In our unit, we had a situation a few years ago where we had an 18-year-old patient, a schizophrenic patient. He was a male. He was admitted to our unit, and he had some problems with, he didn't like male caregivers, and he did not like African Americans. And so it was very difficult to take care of this patient and try to give him what it is that he needed. He refused to communicate with the nurses. He just did not want to have anything to do with anybody. He was a very, very large gentleman, and he was very intimidating to the staff. The staff were kind of fearful of him because, the fact he wasn't communicating and he had kind of that look in his face. And on a couple of different occasions, the patient all of a sudden just became really agitated. And I know that starting from point 0 to 60, there was probably a few situations or maybe some things were said in between, but the patient became agitated. He was placed in wrist restraints, and then all of a sudden he just snapped. And he broke the wrist restraints, grabbed an IV pole, and started chasing the nurses. What his intentions were, I don't know. But what type of things in that scenario would we need to do, and what should we have done so that things didn't escalate to where they had gone?
Well, if you're regardless of what the illness is, don't look at the title in some instances, but look at what they're going through. If you're dealing with a schizophrenic and many of the other illnesses, is he hallucinating? Is he distracted and preoccupied? Is he distracted and preoccupied to the point to where he's not even hearing you or seeing you when you're talking with him? He might think, if he is hallucinating, that you're the devil coming after him. So he's going to be afraid. So that's where maybe his perceptions of other types of people were harmful to him. He might have been, unfortunately, been a very prejudiced person to begin with. We don't know. But remember what we talked about earlier, that we still have to be professional. We still have to deal with it in a healthy way, in a professional manner. What we could have done, if possible, and this is just conjecture here, we really don't know, but what we want to do is to make it so that we give ourselves the best odds of a positive outcome and give him the proper care that he needs. So you hear that he's a schizophrenic. He has these feelings towards males and females. Things that pop into my mind right away are talking to the doctor and making sure that you have medicines ready for PRNs to sedate if needed. But also, too, in talking with him, keeping that positive attitude. Hey, you're in the hospital for a reason. We're going to help you. Here's what we're... I hesitate to say that, because if you tell him what you're going to do, will that cause him fear? Will that cause him to lose control? Or will that help calm him? We don't know. This is where maybe a psychiatric evaluation might be helpful as well, too. If a person is hurting so bad mental health-wise, you can say everything you can and it may not make a difference. So this is where medicines come in, this is where evaluations come in, and then getting instructions from the doctors as to what to do. When a person's in restraints, what have you taken away from them? You've taken away control, and you've taken away many other things that might really make them feel terrible. So what can we do to reassure them? You know what? This is not a punishment. This is just to help you maintain control, and when you get back into control, the restraints come off. Again, chaplain services might be something too. Family members, I don't know. This is where you're going to have to sit down and talk it over with your shift supervisor, other people that have dealt with the person in the past, prior shifts, in terms of what to do and how to help him. What else happened with the person there? He became violent and went after?
Yeah.
Well,
yes.
by then,
what kind of things can we say to him, without not only jeopardizing ourselves, but making sure that the patient is safe? Because we do want to keep everybody safe.
Right. When a person gets to that point to where violence is a possibility, telling them to take it easy, you're going to be fine, isn't going to do it. You've got to make sure you have people who can call security. All right, so we've discovered that we have a schizophrenic patient. He is displaying paranoid tendencies here. He's very intimidating just with his stature. But think about what we talked about earlier. Staying calm, and I know that might be a tough thing to do, but stay calm as best you can. Another thing that we can ask you to do is call for assistance. Have another staff member there with you while you're doing some of these functions of care, and then this way you have one person watching the patient, you have your eyes focused on the work at hand. You're avoiding a power struggle. A lot of folks who are dealing with mental illnesses tend to get into power struggles. Avoid it. If a person says something, either agree or disagree, act accordingly with what they're saying, and you can go from there. Assess whether or not they are taking their medicines. Some patients might be in denial that they are mentally ill, and so when you go to give them a medication for mental illness, they might either refuse it or they may cheek it in some way. So mouth checks might be something to consider and think about. We talked about earlier about listening. This might be a chance. Even if they're incoherent, they're not talking straight, nothing's making sense, agree with them. Go with the flow with what they're discussing for a few moments. Again, it helps with that ventilation, and it might help de-escalate the issue that you're going through. And again, what we talked about earlier, offer that support. And it may not be in terms of the specifics of what's happening. It could be something as simple as that, you know what, Mr. Jones, you're going to get through this. We're going to get you through this. You're not alone, and we're going to help you. And reiterating that. In many instances, people who are having mental illnesses may have trouble with memory. So you might have to reiterate this throughout your shift. But I tell you, reiterating the positive is better than a power struggle or any other things that we were talking about earlier.
Okay.
What's the next one?
Well, we had another patient. He was a young Polish-speaking gentleman, very young guy. drank about, well, I can't really tell you how much he drank, but he was a fairly heavy drinker, and drank hard liquor on a daily basis. He came to us. He was oriented at most times, but disoriented. He had kind of like the flight of ideas, word salad. We did have an interpreter in there in the room with him to kind of help us. And however, a lot of the times he was mumbling. His speech was very slurred. We had a hard time making out what it is that he was saying. But and I don't know if that may be the issue as to why the situation escalated to where it was, but the patient became very agitated. He was, slapping the nurse's hands, restless, running around the room, picking at his IVs. He was getting in the nurse's faces.
Starting to lose control.
He was starting to lose control, I think, within himself, but even with the nurses trying to help him, I don't know if it was a miscommunication with, a language barrier, but the guy was a fairly big guy, very nice gentleman, but then he started becoming very verbally aggressive. So what type of things in that situation would we need to do to not only prevent it from getting higher, but he's already starting to hit his wall?
Right. Well, look at what you're dealing with. You're dealing with alcohol, and what does alcohol do to a person? It takes control away from them. In many instances, we keep things as simple as we can. We're also dealing with the language barrier too, so can an interpreter be there or not? If an interpreter is not there, that might just make things worse or make it more difficult for you to help this person here. So you've got a big mountain to climb before you've even started the journey. And then in this way, what can we do to help for future things? In terms of dealing with this person at this point in time, we can do the de-escalation techniques and look at what it says. He's starting to lose control. He's slapping people, going across the room and so forth. Saying don't do that, or again, raising your voice, it won't work. Keep that calmness as best you can. Keep that professionalism as best you can. Easier said than done, I know, but it helps all the way around. Power struggle, I don't know if a power struggle can be with that because he may not understand what you're saying and we're not understanding what he's saying. So the power struggle might be simply with his physical actions. So that has to be looked at too. Again, that's where the interpreter can help us. All right. What does the CWA say? What were his CWA scores? Were they high? Is he displaying many of the signs and symptoms that you would see? Sweating, confusion, disorientation, etc. And then what medicines can we do to help him with that? So yes, keep professional, yes, keep positive, but to go for an extensive verbalization of things doesn't. What types of medicines can we get? This is where the CWA thing is so important, because the earlier you act on high CWA scores, the better withdrawal symptoms can be avoided, and the less severe the psychiatric symptoms might be looked at too, or avoided too.
So it's important that the nurses actually give the medication based on the CWA scale, and not to be afraid to give the Ativan if the score is an 8, a 9, or whatnot.
And this is where the doctor's guidance comes in, because that's why we have to look at these CWA scores. The CWA scores give us an indication of what the person's body is going through on the inside. And if these numbers relate to what the person's going through, we need the doctor's guidance as to how much medication and when to administer it. So it's very important. The two go together, but they can be very powerful and help de-escalating the patient and giving that patient some relief from other withdrawals that they may go through, or even more severe withdrawals that may come later on down the line. That's what you don't want.
So to tie things in together, I guess basically you're telling me the important thing is to stay calm, be professional. You want to avoid power struggles, and you want to make sure that you're actively listening to the patient, and that you're recognizing your responses, your verbal and nonverbal communication, because that can be, based on the patient's perception. That's where you need to be careful and make sure that you are doing what you need to do to keep this patient safe and to prevent any situations from escalating.
Correct.
So we need to continue to offer them support and reassurance, and we need to constantly assess and reassess the patient on an ongoing basis.
And I might point out to be fluid, to be flexible, to understand that, okay, maybe I need a second pair of eyes on this. Maybe I need someone else's opinion to help me with what I'm trying to do. a lot of times we talked about anxiety. And when a person is anxious and it turns into fear and then anger, if we can deal with it at those beginning stages, it's going to take or solve a lot of problems later on down the road. And it's going to go back to what we talked about. What's the most important thing that we're here for? To help the patient get through this.
Very good. Well, I thank you very much, Ken,
You're
for
welcome.
doing this for us.
Sure.
And I think this is a wealth of knowledge, and I think it'll help us quite a bit in any of our escalating patients to hopefully de-escalate them appropriately so that we keep our patients safe.
That's right. That's what it all boils down to.
Thank you.
All right, take care, everybody.